get straight into it. Okay, so this is the roundup for the week 5 practical session where we focused on abnormal haemoglobins. So you had a couple of things to do in this session. So you had some videos to watch to be able to see what a haemoglobin solubility test looked like, and the majority of the time you would have spent looking at activity 3, interpreting the haemoglobin cellulose acetate results, and you would have also tried to interpret your blood film case studies as usual and answer the questions. And remember, the really important thing with your blood film case studies is to make sure that you are able to justify your provisional diagnosis, make a nice summary of your films and justify your provisional diagnosis, and also with your further differentiating tests to be able to tell me why you want those tests. And the reason that I do that is just so that you don't try and choose or think about every test that you can ever think of. There has to be reasons for you wanting to do the tests. So if we have a look at the blood film, the hemoglobin cellulose acetate first, I'll go through them with you one at a time before, and then I will actually publish the answers for you at the end. So the first patient, patient A, was 28-year-old female, Red Cross donor, no history of anemia. So that history is telling us that this person is feeling fine and happy. So they're not feeling unwell. The reason they're having a blood sample taken is just to check their hemoglobin before they give blood, basically. So when we had a look at the full blood count, we find a red cell count of 5.49 times 10 to the 12th per litre. And for a 28-year-old female, that red cell count is very good. It's in the high end of the reference interval for female red cell count. Her hemoglobin is 115, which is low. So that is below the reference interval at 125. So she's got a very solid, good red cell count with a low hemoglobin, and her MCV is 65. As soon as you see that pattern with the high red cell, or the normal or up top end red cell count with a low hemoglobin and a low MCV, then the first thing that you need to think about is that the fact that this person has got a thalassemia or some form of quantitative abnormal hemoglobinopathy. And then the picture of microcytic hyperchromic comments there, that feeds into that picture. And what's really important there is the target cells, the fact that there are a lot of target cells there. So when you look at our rather amateurish drawn hemoglobin electrophoresis, what you should have noticed was an increased band in hemoglobin A2 on the alkaline electrophoresis. Now, this increase in the A2 band, with no noticeable increase in the hemoglobin F, would make you start thinking about some form of beta thalassemia, so or an alpha thalassemia for that matter, seeing it's hemoglobin A2, but something fairly minor, so some sort of a trait. But the other thing that you must remember is that there are some abnormal hemoglobins that will also give you a low MCV. So normally, abnormal hemoglobins are a qualitative defect, not a quantitative defect. So normally, with our abnormal hemoglobins, we would get a normocytic anemia. So the MCV would be normal. But there is one particular abnormal hemoglobin that actually gives us a quantitative defect as well as a qualitative defect, and that is hemoglobin E. Hemoglobin E travels with hemoglobin A2, as does hemoglobin C. So those two hemoglobins travel with A2 under alkaline electrophoresis. Hemoglobin C does not travel with hemoglobin E and hemoglobin A2 in acid electrophoresis. So when we have a look at the acid electrophoresis for this patient, we see that there is no hemoglobin C line visible. And so this is able to discount hemoglobin C. The fact that this person has got a lot of target cells in their blood film suggests that it's more likely to be hemoglobin E. We do get target cells, of course, in microcytic hyperchromic anemias caused by other things, but not as many as we get with hemoglobin E. That really is a hallmark of hemoglobin E, the number of target cells that are there. And this is a case of heterozygous hemoglobin E, and we write that as HbAE. Okay, so as with most of the abnormal hemoglobin variants, hemoglobin E is an abnormality in the beta chain, and therefore it tends to reduce the amount of hemoglobin A that's produced. And so that's why the heterozygous form, we've got one normal beta globin gene and one abnormal beta globin gene. And so that's why it's the A that's being affected, and that's why we call the heterozygous form of this condition hemoglobin AE. If it was the homozygous form, we would use the notation HbEE, and that shows the homozygous. Has anybody got any questions about that first patient before I move on? You can type them if you'd rather not voice them. Okay, so nobody's put up their hand, so I'm guessing that I can move on. So the next patient, patient B, is a 32-year-old male. We don't have any history for this patient. When we have a look at the full blood count, we can see that the red cell count at 4.97 is in the normal reference interval for a person in this population. The hemoglobin is 120, which is a little bit low, and the MCV is low as well at 73 femtoliters. So again, we've got that normal red cell count with a low hemoglobin and a low MCV. Sorry, I've jumped to number question patient C. Red cell count 4.97 is normal, hemoglobin 120, MCV is 84. So this is on patient B. So with that MCV of 84, we would consider that to be normocytic, and so we're probably looking here at a hemoglobin variant rather than a thalassemia or an iron deficiency. And so when we have a look at the electrophoresis for this person, we see there is a clear band of showing at hemoglobin S. So remember, when electrophoresis is performed, we subject the hemolysate solution in the buffer. We subject that to an electric current which mobilises the hemoglobins and separates them out. But before we can visualise that, we need to stain it. And so staining of those bands is very important. And so for patient B, there was a clear band of stain visible at hemoglobin S, at the position for hemoglobin S. And so this suggests that this is sickle cell, and it's sickle cell trait because if you have a look, compare hemoglobin S band to the hemoglobin A band, they're sort of roughly equal. The hemoglobin S might be a little bit smaller or lighter. And so because it's less than 50%, we call this a sickle cell trait. Because they've got normal FBE and blood film, that sort of plays into that diagnosis as well, because if you had, if it was homozygous sickle cell disease, then even though this person's obviously not in any sort of a crisis, you would still have some sickle cells visible in the blood film. Not many, but you would still have some there. So this is a heterozygous sickle cell anemia, and so we call that hemoglobin AS. So patient B has got sickle cell trait. Now moving on, before I move on to patient C, has anybody got any questions about patient B? No? Okay, so on to patient C, 38-year-old female, GP checkup, tired. Remember that 6/12 means 6 months, query depression. So again, this person, yes, they're feeling tired, which of course we know is a cause of, or it's a sign of anemia. And so, you know, when we look at the full blood count and see a hemoglobin of 110, that is a mild anemia and could be what's causing her tiredness. However, again, when we have a look at the red cell count for this person, the red cell count is very robust and again is up at the high end of the reference interval for this population. And the MCV is again low, so this is microcytic. And we can see from the blood film comments that the red cells are microcytic hypochromic and there are a few target cells around. So this picture really does fit very well, again, with the person having some form of quantitative hemoglobin defect, such as a thalassemia. But of course, whenever you get a low MCV, and this pertains to patient A as well, whenever you see a low MCV, the first thing that you need to discount is iron studies, particularly in women of childbearing age, because as we know, iron deficiency anemia is the most common cause of microcytic anemia worldwide. And so we do need to discount iron deficiency anemia, and we do that with iron studies that we'll learn about next week. So when we have a look at our hemoglobin electrophoresis, we notice there's meant to be increased staining in the hemoglobin A2 region. There's no increase in hemoglobin F. It looks like it's more likely to be a thalassemia, and if I told you for this case that the iron studies were normal, then that tells us that it is some sort of a thalassemia. So we would require, because there are a number of things that we need to discount here, so there are some hemoglobinopathies, as we know, that can cause this sort of a blood picture. So we could do other further testing to help to differentiate things that we can't differentiate with our thalassemia, and again this would apply to patient A as well. We could do something like HPLC, which is more sensitive to be able to measure things, and also hemoglobin A2 quantitation would help us too, because that would help us to differentiate between beta thalassemia and alpha thalassemia. Although in this case it was a beta thalassemia trait. Has anybody got any questions about that case or that patient? Okay, I'll keep going. Now, what I'd like to do is to jump to patient E now, because when we have a look at the full blood count results for patient E, we can see that the MCV is 73 femtoliters, is exactly the same as the MCV for patient C. Now, we've already been told that patient C is actually diagnosed as a beta thalassemia trait. So we need to, let's look at the full blood count results for patient E compared to patient C. Patient E, we have a red cell count of 3.22, which for a female is low, whereas we had a red cell count of 5.22 times 10 to the 12 for patient C, which was, as we know, up near the top of the reference interval. So there's one difference between these two patients, even though we've got an MCV of 73. the hemoglobin for patient E is low, as it was for patient C. It's more of a moderate anemia, whereas patient C was really only a mild anemia. So you can see that the pattern between the red cell count, the hemoglobin, and the MCV for patient E is different to the pattern for patient C. Patient C, we have an upper normal red cell count and a low hemoglobin with a low MCV, whereas patient E, we have a low red cell count, low hemoglobin, low MCV. So in patient E, this pattern really is much more indicative of an iron deficiency anemia than it is of a thalassemia or an abnormal hemoglobin, so a hemoglobin variant. And so the comments, the blood film comments are very similar for both. We have some elliptocytes in patient E, which we don't have for patient C. So when you had a look at the hemoglobin electrophoresis results for patient E, they were quite normal, or they were meant to be normal. We aimed for them to be normal. And so, again, to determine that this was iron deficiency anemia rather than an abnormal hemoglobin, we would do iron studies. And of course, anytime, as I said before, if you get a low MCV, iron studies would be your first test that you would suggest. And in fact, this person had iron deficiency anemia. So we'll jump back to patient D. Patient D, 28-year-old male. Again, no drama here. Blood donor for student practical, no history of anemia. So this person, when they say no history of anemia, what they're saying is that, you know, there were no clinical signs and symptoms or indications that this person had had anemia before in the past. And so, again, this is a serendipitous finding with this person. So we've got a red cell count of 5.1, which for a male is quite normal. It's sort of right in the middle of the reference interval there, 5.01, sorry. The hemoglobin is 129, so that's just on the low end, right on the, just below the reference interval. So again, the hemoglobin and the red cell count don't really match here. The MCV, however, is 83, so that's normal. So we've got a normocytic, normochromic anemia here, and it's only just anemia, I guess. So again, with that sort of a picture, you might be considering some sort of an abnormal hemoglobin, and with that MCV of 83, probably not thinking about a thalassemia so much, but you certainly, you know, it might be a very mild one. And the electrophoresis strip was meant to show an increase in hemoglobin F, particularly in the acid gel. So we see an increase in hemoglobin F anytime we get abnormalities within the beta globin chain. So that could be beta thalassemia, and it could also be a condition known as hereditary persistence of fetal hemoglobin, which in fact this is. So ways in which you could differentiate this from beta thalassemia, you would look for basophilic stippling in the blood film. So that would be present in beta thalassemia, but it wouldn't be present in hereditary persistence of fetal hemoglobin, HPFH. You can even do some hemoglobin F quantitation, and one way that you can do this is a test called the Kleihauer test. And this test is often used to detect fetal red blood cells in the maternal circulation when we're looking for a condition known as hemolytic disease of the fetus newborn. So you learned about this when we were learning about immune hemolytic anemias. And so you can actually quantitate the amount of fetal blood in the maternal bloodstream by staining the hemoglobin F. And so this same method can be used in to help us to quantitate hemoglobin F in other conditions such as this one. And this is actually a case of hereditary persistence of fetal hemoglobin. There was about, I think there was about a 10% increase in the the fetal hemoglobin F in this case. And usually hemoglobin F is down around about 1% or less than 1%. So this is quite a benign condition. About the only thing that happens is the fact that the red cell count is increased because hemoglobin F has a higher affinity for oxygen than hemoglobin A does. And so that means that the oxygen is not given up to the tissues as easily. And so the red cell count increases as a homeostatic mechanisms compensate for that higher oxygen affinity. And so by increasing the red cell count, we're still able to get adequate oxygen to perfuse the tissues. But otherwise, it's at this sort of level, it's quite benign. So now the final electrophoresis case study, so patient F, and this was a really tricky one. This person actually had hemoglobin Lepore. And for those of you who completed your pre-practical questions, you will know that hemoglobin Lepore is when we get a fusion between the genes for the delta gene and the beta gene, and so we get this abnormal hemoglobin. And the interesting thing with hemoglobin Lepore is that it travels with hemoglobin S, and that's why you were given the clue here that it's not hemoglobin S on electrophoresis, but it is it's a hemoglobin that travels. It has the same electrophoretic mobility in alkaline electrophoresis, and so you see a band at hemoglobin S in alkaline electrophoresis, but no band in the acid electrophoresis. So that's telling you that it's not hemoglobin S, but it's another hemoglobin that travels with that. And so there are two other hemoglobin variants that travel with hemoglobin S, and they're hemoglobin D and hemoglobin G. The way that you differentiate them from hemoglobin Lepore is that D and G have a normal MCV, whereas here you can see the MCV is 74, so it looks a little bit more like a thalassemia type picture. So again, you would need to differentiate. Well, the electrophoresis actually differentiates it from beta thalassemia because of the fact that you've got a band of hemoglobin S in the alkaline electrophoresis, but none in the acid electrophoresis. And this person, patient F, was actually a student of ours from a few years ago who knew that they had this condition and very kindly donated their blood, as were patient D was another one too. Okay, has anybody got any questions about those 6 patients? So now that we've had a look at that, what I'll do is I will share the results here, and so then they are recorded and they are in the web room. So you can see the results there. Okay, so now we'll go on and have a look at the case studies. So the first case study we're looking at is case number 1.10. So this is a 44-year-old female, and the clinical history we have is paresthesia of the right hand. So this means that paresthesia is numbing or finger pins and needles type sensation in your fingers, and so that's why we're querying carpal tunnel syndrome. So this syndrome where the nerves actually get trapped along with the tendons as they travel through the wrist from the arm into the hand. And so again, that's what that clinical history is telling us, that this is it's an incidental finding. So this incidental finding is telling us that yeah, it's not expected. It's not what we're looking for, if you like. So the calculations for the MCV, now these are taken, remember that the calculations here are taken from the haematology analyzer, and because the analyzer doesn't round numbers up or down the way we usually do when we calculate, there could be slight differences in what I've got here to what you've got. So don't be too concerned if they're not. I do take that into account, particularly if I have many students with the same result that is different to what I've got. So I can then go back and recalculate and check that. So the MCV is 65, so very low MCV. The hemoglobin is 127, which for this age group is down at the lower end of the reference interval. The red cell count at 6.14 times 10 to the 12th is way up. So it is higher than the top of the reference interval. So again, we've got this classic picture which suggests to us that we have thalassemia. So the very high red cell count, the low hemoglobin, and the very low MCV. When you did the differential count on this, you should have got a count similar to what is written here. Again, it may not be exactly the same, and I usually allow for about a 10% variation either side. The white cells and platelets were normal, although I think some people thought they saw giant. I think this was the one where some people saw giant platelets. So did anyone see giant platelets in this group when you had a look at this video? Yep. So one of you did. It wasn't a feature of the film, but it seems that they were there. So when we summarise this, well, you can see here the red cells, increased red cell count. So if you like, you can call that an erythrocytosis. Microcytic hyperchromic red cells, many of them, and the RD double at 15% suggests that there is a mild amount of, or a small amount of anisocytosis there. So there's 1+ anisocytosis and 1+ poikilocytosis. So when you're summarising this film, you would be saying that microcytic hyperchromic blood picture consistent with thalassemia, or microcytic hyperchromic blood picture with increased red cell count, consistent with an abnormal hemoglobin, query thalassemia trait, something along those lines. And of course, you would justify your provisional diagnosis by pointing out that pattern of the red cell count, the hemoglobin, and the MCV. Further differentiating tests, even though it's not, oh, there we go, iron studies. Anytime you've got a low MCV, include iron studies, even though the patient's not anemic, you never know, they could still have a low ferritin, or their iron studies could still indicate that they have suboptimal iron stores. And we'll talk more about what these actual iron studies are next week, after having mentioned them for 2 or 3 weeks now. So along with iron studies, you would suggest hemoglobin electrophoresis, because of course this is the way that we detect and differentiate many of our abnormal hemoglobins. Hemoglobin H, so you may recall that hemoglobin H is formed by 2 pairs of beta chains. So this is when we have excess beta chains that pair up together and cause a beta tetramer. And when we have excess beta chains is when we don't have enough alpha chains to match up with them. And so we see this in alpha thalassemia. So you can go and check in your notes about how we actually detect hemoglobin H. And then the other thing that we do is we would have molecular studies to isolate and identify what the actual genetic abnormality is. Has anybody got any questions about that case? Okay, we'll move on to the next case. So this is case number 1.15.2. This is a 13-year-old female. She's a humanitarian migrant. So we're not sure where she's come from, but she's not She's not Australian born, and from the look of her age, she may not have been here for very long. We don't know how long she's been here. So when we have a look at her for blood count, we see her hemoglobin is 92, which for somebody her age is low. So that is a moderate anemia, getting down to being a severe anemia, or severe is below 80, so it's a moderate anemia. The red cell count is low as well at 3.05, but the MCV is 85, so that's normal. And the RDW is 24%. So we've got quite substantial anisocytosis that we would expect to see on the blood film. And the reticulocyte count is 13%. I must admit, I tend to go with the percent rather than the absolutes, although our normal absolute has a top of about 100 times 10 to the 9th per litre. So you can see that the retic count is substantially increased whichever way you look at it. So when you see a normocytic blood picture with a lot of anisocytosis and an increased retic count, that should suggest to you that we've got some sort of a hemolytic condition going on here, because that RDW is showing us probably that we've got either, we could have spherocytes there, we could have a lot of polychromasia there. When we have, and the reticulocyte count is certainly pointing to some sort of a hemolytic situation. So when we have a look at the blood film, we see normocytic normochromic red cells, anisocytosis and poikilocytosis, significant polychromasia at 3+, Howe jolly bodies and sickle cells. So sickle cells 2+ and target cells 2+ as well. So this is the case that we did the hemoglobin solubility test for, and that test was positive. So both by looking at the blood film here, we can see that this person has sickle cell disease, and the number of sickle cells that are there suggests that it's probably sickle cell anemia, so homozygous sickle cell disease or hemoglobin SS. So when your summary and provisional diagnosis, normocytic normochromic anemia, hemolytic anemia if you wanted a gold star, and with sickle cells, query sickle cell disease or some sort of hemoglobinopathy, because you may recall that there is another abnormal hemoglobin variant that has cells that are sort of a similar shape to sickle cells, although they've got much blunter ends. And this is in hemoglobin C, where we get crystals being deposited in the red cells. And so you would still need to do your hemoglobin electrophoresis and also do your hemoglobin S solubility to differentiate hemoglobin S from hemoglobin C. So remember that the hemoglobin solubility test detects hemoglobin S, but it doesn't tell you whether you have got heterozygous or homozygous hemoglobin S. It just tells you you've got hemoglobin S there. But the solubility test is negative for hemoglobin C, so that's a very useful test. And also hemoglobin electrophoresis will help us to differentiate these two conditions, which are quite similar. Looking at the white cell count, so the white cell count was 14, and so that is above the reference intervals, so that suggests there is some sort of stress going on. So it seems that because this person, there's a lot of polychromasia there, so there's a hemolytic crisis going on, so it suggests that, yeah, there's some, there's an oxidative crisis that's, or a vaso-occlusive crisis is what we know, and what we call it. The Howe jolly bodies suggest to us that the spleen has been affected by the sickle cell sickling, and usually the spleen is the first organ in the body that shows the effects of the sickle cells, and often we get a condition called autosplenectomy, which is the answer to the question that is below this, this case study. So the How Jolly bodies suggest that this person's spleen, she's either had a splenectomy or her spleen is not functioning. The white cell count feeds into the fact that she's having a sickle cell crisis and that there is tissue damage. We actually have a lymphocytosis here rather than a neutrophilia. So there's a lymphocytosis and a monocytosis. So the monocytosis is telling us that the tissue damage is ongoing. There could be something else here that's causing the lymphocytosis, although this person at the age of 13 may still have, that slightly reversed diff might be coming into play here. And we've got a thrombocytosis with a platelet count of 727, and that's also indicative that the spleen is either not there or it's not functioning, because we usually carry about a pool of about a third of our platelet count in the spleen. When the spleen's not there, the platelet count is usually higher. Any questions about that case study? Okay. On to the third one. So here we've got a 24-year-old female with an upper respiratory tract infection. So once again, she's going to the doctor with something other than feeling tired and unwell and anemic. She's got an infection going on here. We look at her hemoglobin, it's 101, so she has a mild anemia. Again, a very robust red cell count and a low MCV, which suggests that she's got some sort of an abnormal hemoglobin here. RDW of 22% suggests that there is some anisocytosis there, and also her platelet count is up at the high end, so it is increased, although we see that the platelets are normal. The white cell count is also normal. The thing that we notice with the white cells is that there are reactive lymphocytes there, but that might tie in quite nicely with her upper respiratory tract infection, so it's suggesting that she's got a viral infection. So when we have a look at her cell morphology, we see the red cell acidic hyperchromic with moderate anisocytosis and poikilocytosis, target cells, and also cell fragments are seen there as well. So we're not quite sure at this stage what we've got here, probably some form of a thalassemia. So the summary is a mild microcytic hyperchromic anemia with, it says normal red cells there, but they're, I guess there's no, by saying normal cells, we're saying that there aren't any obviously obvious forms of cells such as sickle cells there. So because it's microcytic, we need to differentiate iron deficiency anemia from the other abnormal hemoglobins that cause a microcytic picture. So beta thalassemia, alpha thalassemia, hemoglobin E. So slide 1.14.2, I don't know how many of you had a look at that one, but that is a hemoglobin H preparation. So that is a supravital stain that picks up the precipitated beta tetramers that we see as hemoglobin H. And because that is positive, then that tells us that this is actually an alpha thalassemia. And so they are the tests that you would do along with the hemoglobin H preparation to check for alpha thalassemia. And you could also do, things like HPLC or isoelectric focusing or things like that to semi-quantitate the hemoglobin A2. So has anybody got any questions about that case study? No? Okay, so we'll go on to the final case study, seeing it's up to 5 o'clock. Sorry, I'm taking longer than I thought I would. So case number 1.11.2, 37-year-old female of Mediterranean ethnicity, and we know that this person is post-splenectomy. So as soon as you see that post-splenectomy, you should be prepared to see the red cell changes that go along with a post-splenectomy. We're not sure what's wrong with this person. All we know is that they've got 117 nucleated red cells per 100 white cells. So we do need to correct the white cell count here. And you can see here that the corrected count that I got was 6.04, so 6.0 times 10 to the 9th per litre. The formula that is given for you here is the same as the formula for last week, which is different to the formula from the week before. So I think the original formula that you were given is the easiest one. I don't really mind which one you use. Both of them give the same answer. The red cell count you had to calculate, and it should have calculated out to 3.1 times 10 to the 12th per litre. So when we have a look at these compared to our reference intervals, the red cell count is a little bit low. The hemoglobin is low, is very low, and the MCV is 81. So the MCV is sort of, this is a really tricky one. The MCV is right on the cusp of being normocytic and microcytic. The red cell count is low and the hemoglobin is low as well. So again, we've got an increased platelet count and an increased white cell count. But of course, that increased white cell count does include the nucleated red cells, so that will bring down the cell numbers when you calculate the correct number, which is what is calculated in the red there. So when we look at the red cell morphology, we see that we've got normal, slightly hyperchromic red cells. So there's marked aniso and poikilocytosis, some microcytosis. So we've got a variation in the size of the cells there, how jolly bodies, target cells, and also Pappenheimer bodies. Did anybody who saw the how jolly bodies in this film? Just pop up your hand if you saw how jolly bodies. Nope, nobody. And who did anybody see Pappenheimer bodies? So Renee, are you hands up for Pappenheimer bodies? Wow, well done, because they're quite tricky to see. Did you see how jolly bodies as well, or just the Pappenheimer bodies? Okay. Yep, just the Pappenheimer bodies, right? Thank you. So yes, and so they're all sorts of things, you know, that aniso and poik and the microcytes and the target cells and how jolly bodies and Pappenheimers. That's all the sorts of things there with the post-splenectomy. So so you can see here why was the post-splenectomy performed, and you can see down the bottom there it is a treatment for hemolytic anemia, but also for other forms of abnormal hemoglobin where the red cells are being prematurely destroyed as well. And so it is a way in which a number of conditions are treated to try and prolong the life of the red cells. And of course, sickle cell anemia, it's often removed because it's no longer working. And once an organ in the body becomes non-functional, then there is a chance that it may become necrotic. So it's a good idea to remove it. So because of the, we wouldn't really need to do any further tests because they obviously know about this person's background. So, but if you were going to do some further tests, of course, it's hemoglobin electrophoresis that you would do to see if you can pick up some sort of an abnormal hemoglobin. Okay, has anybody got any questions about anything that you've done today or any comments about how you found doing an online prac? So what I'll do is I'll stop the recording and then you might like to make some comments then.